It's always somewhat difficult because I am coming from the medical background, and I know that you guys are going to look at from your work point of view, so I will hopefully do that. My apologies for the spellings. I think I have a block about uh, trying to remember the names of the drugs of abuse. So this should be OID, opioid. So I didn't catch it until a couple of days ago, and by that time I had already submitted these PowerPoint. So please correct that. And oops, I'm looking at myself. So so do I? I'm trying to push. Oh, okay. Okay, so I press on this side? Okay, thank you. So just I'm going to quickly go over some of the numbers that probably you already know. And I think it's nice to know these numbers somewhat change and drugs of use change. But I think across the board, about 11 million, 11% or 8.3 million children live with one of the parents who uses either illicit drugs or is an alcoholic. And multiple drugs are very common and to about 1/4 of the children living with the parents. Gosh, I don't want to see myself. So, okay. Um, so whenever the parents are involved in the substance abuse, whether it's legal or illegal, it increases the risk of child abuse in a child. Go one back. So I don't know what's doing. It keeps coming back. So a lot of times, next one. Okay. So about 40% of the cases of child abuse that are reported nationally, there is always a substance abuse. Even though in subclinic, one time I ran the statistic in my clinic. Of course, I ran a clinic for the abused children, and in those families, the history of substance abuse was 75%, which was surprising to most of the national and international people. But when you're looking at across the board families involved in child welfare, then you come across pretty much what I found in my clinic, and that is up to 80% of the families have a history of substance abuse when they are involved in child welfare system, and that's from the juvenile justice becomes important. Important issues that we need to know is, regardless of what people say, that I used before I knew I was pregnant and all kind of comments, women who start using substances while they are not pregnant will continue their substance abuse during pregnancy, and often more than one drug is used. A lot of time people don't mention those illegal drugs like alcohol or cigarettes when they're pregnant, but they also can have an impact on how that affects the child medically. There are certain times in pregnancy which are more at risk. Women are more at risk for going up or breaking through their recovery time, and that is the first and the third trimester of pregnancy. So when women are prescribed the certain steroid preparations, SSRI drugs, they will also cause the neonatal abstinence syndrome because they also go through the same dopamine dependency cycle that opioids do. So we need to aware of that. For women what kind of drugs they're going to use sometimes most often depends upon who they're in relation with. And if their significant other is on a different drug than they started off with, the women will switch their drugs. So also that history becomes important. These are some of the common drugs of abuse. And in prescription drugs, that's where the opioids come. We need to also remember that substance abuse does not exist alone in a person's history. There are about anywhere half to two-thirds of the people who have underlying mental health diagnosis. A lot of time these families will have co-occurring domestic violence. They have history of childhood trauma that you need to take into consideration. I'm not going to go into the detail because I know you guys are going to have a lecture on that. And other issues that may or may not be related to that existed before substance abuse started or secondary to that, or lack of like losing the source of income, becoming homeless, poor, and illegal activities, and developmental disabilities often in parent. And I think that I can't emphasize enough that even though we are focusing on the child, some often parents have undiagnosed developmental disabilities, and that can have an impact on how they're going to process the information that you are giving them, in how their case is going to go, how they are going to be compliant as far as the follow-up services are, whether or not they are going to remember their appointment schedule. And those, one of the common one that people are walking around undiagnosed is fetal alcohol spectrum disorder, those adults. In the, again, sorry for the misspelling, there had been a tremendous increase in the opioid drugs among women and among all populations. And I think lately more at risk are the children in the juvenile age range. So there has been the latest one from the Center for Disease Control this week is that 3 out of 5 deaths in America now are contributed to the overdose by the opioid. And that is a very scary statistic that they have come up with. As women go through the pregnancy, because of the different factors, because of the stress of changing hormonal levels, they often increase their use of prescription opioids. So we need to be aware of that. And also changes in the methadone dose increase during pregnancy. It may be to keep the mom safe from having untoward side effects during pregnancy and risk to the unborn child, but it does increase the potential for the withdrawal symptoms in the newborn child. And so we see increased number of children that are born with the drug withdrawal in the United States. In the maternal, other medical health issues for the women, losing weight, not eating, having poor nutrition, poor hygiene, are similar to what we saw in the crack cocaine users. And also there are commonalities that all of the drugs of abuse impact the fetal growth, some to more extent like alcohol and some to lesser extent. But almost always the children are born a little bit less weighing and smaller in length. But these are really hard to estimate because you need to know what the average height and weight of the other children in the family is. So often this is something that is missed major time. And there has been few studies, still not a whole lot of studies on what the intellectual impact on intellectual development is on children who are exposed to either a prescription opioids or to methadone treatment, which are the same. In the babies, we often see, like I said, the drug withdrawals and small size babies. 50 to 90% of the babies will exhibit the withdrawal symptoms. And if the mom's dose of methadone has gone up in the pregnancy, that will increase the severity of the symptoms in the babies. And again, the severity of the withdrawal will increase if the mom is using tobacco concurrently or the other steroid-related releasing substances for other mental health issues. So there is often a compounding of effects if the parent is using other prescription drugs for other medical or mental health issues. Most of the babies start showing the effects within about 3 to 4 days. And unless we recognize mother's history, these babies can go home and not showing any symptoms, and then starts showing symptoms when they are at home. So they require observation in the hospital if mom has a history of methadone treatment or prescription drug abuse. And up to 12 months of age, these children are sometimes going to have some kind of symptoms. So it's not something that you have a week of stressful time for the mom and gets done. These children are very difficult to take care of, especially if the parent herself is going through um, issues of substance abuse and opioid withdrawal. And many of these symptoms in the babies have to do with either the irritation of the central nervous system, like they will have screaming, crying episodes and very squeaky, high pitched crying. They will be very irritable. They will have a very restless sleep and awake pattern. They will not, babies are pretty organized. They can go from awake cycle to sleep cycle. And these babies do it very disturbing way. They'll also have problem with suck and swallow. They will have a very compulsive suck, frantically trying to eat, and then they will start throwing up. Some of the babies may have also loose stools, fever, sweating, stuffy nose, excessive sneezing, increased heart rate. Blood pressures are hard to measure in the babies because they're crying so much. But if you can get a baby in the quiet state, even then their blood pressure usually is up. So the first thing that medical professions do, and depending upon how bad the baby's symptoms was, that you can use. I don't know how often you will need this information, but there is a system of scoring which was started in the 1970s by Dr. Loretta Finnegan. It is still used. It's now called the neonatal abstinence syndrome or NAS scoring system. And most of the care of the babies is that you want to make sure that they don't get dehydrated, they are sweating, they don't lose so much fluid from diarrhea, vomiting, sweating. Give them quiet place with minimal stimulation when they are irritated. With the severe symptoms, you have to follow them closely because they are on medication. There are some areas that are requiring babies to have special nurseries because many of these babies, when they start having symptom, go to the neonatal intensive care unit, which is really developed and a design for the babies who are born premature for severe medical problems. And it can become pretty expensive, and also not all personnel there can can develop an expertise for taking care of the babies who are having the abstinence syndrome. So a lot of the medical facilities have extended those nurseries to for the babies who are going through the withdrawal, because these children can stay there for weeks or sometimes for up to a month. And so you also need to have a medical team that can provide the close follow-up for these babies. So the picture becomes complex because you need to sort out the different symptoms from how much symptoms baby is showing from opioids and what are the other symptoms, whether that is prematurity, and that can affect how the baby is going to be eating, whether the baby has underlying heart problem that is causing the problem with blood pressure and heart. You also need to look at combination of alcohol exposure and opioid exposure and how that can have an impact. And the prescription drug exposure, methadone drug exposure, they will, even though you may have a regular therapeutic dose of methadone, you can have a severe abstinence syndrome because of concurrent prescription drug exposure. And also now we have a lot of states with the medical marijuana use, and people are using opioid when they're using marijuana medically. So that can also potentiate the baby's growth problems and also the baby's abstinence syndrome. And the issue that comes in the juvenile courts more often is the child needs to be placed with either extended family or in the foster care, and mom insists on breastfeeding the child, and that becomes an issue. And so you can, we need to discuss that. I'll do that. Okay. So for most of these cases, we need to develop a collaborative response, because you need to have all the agencies that are involved in the mom's care, in the baby's care. They need to come together, including the mental health professional, the drug treatment professional, medical providers, early education staff to evaluate the development and follow up for the baby. Family support services are important to provide the stability in the parents' life and to look at their, but most important than not, having the parents tell you what priorities are there, because of course these people have multiple needs, and if you give them 25 different areas to work on, they are not going to be able to be successful and not tackle that. So have them prioritize what is the most important thing for them to look at. Okay, so now I'm going to go to the caring. Ooh, if I can get to that. I think I can, but if I can bring this fast moving object. Just going into a little bit more detail for specifically for these kids. Okay, I can go from this slide. Okay. And this is something that is not just specific for the children exposed to opioids, but also children who are substance abuse to other drugs. So I already talked about the neonatal abstinence scoring system, which is used. Neurobehavioral exam is something that is not a routine in all the well child exams. Typically, the baby's heart is listened to, and the lungs and arms and legs are moved, and as long as the baby is doing that, the baby is declared normal. But neurobehavioral exam is very specific. I did that as a part of my research and learned it when we were doing a research on methamphetamine exposed babies, and that looks at the baby's organizational skills. Newborn babies are very well organized because if you know that a baby within 1 minute of birth have to learn and do it correctly with 100% accuracy, 6 skills that they have never done before, and that is to keep their temperatures stable, to eat and poop and breathe, okay, and to respond to all the people who are giving them slobbery, mushing kisses, adjust to that. All of those things the babies have to master with 100% accuracy within 1 minute. And most babies are able to do that. And for all the bright people in this room, if I gave you 6 skills that you've never done in your life, and asked you to perfect that, perform with 100% accuracy within 1 minute, I don't think any of us can do that. And babies do that. They are very well organized. So that neurobehavioral assessment looks at the brain's organizational skills in the babies. The Infants exposed to methadone, longer stay of hospitalization is needed. So there is plenty of time to assess these babies. So in one of some of these regulatory tasks or organizational tasks are regulation of life-sustaining functions, keeping the temperature, breathing, keeping the heart rate. Babies should be able to do that pretty at a stable rate. Able to tell when they're hungry, able to quit eating when they have had enough, and be able to sleep and awake in an organized manner. And like I said, to be able to respond to social stimuli without going berserk. Okay. So most babies who are organized will sleep about 6 to 8 hours regularly by the time they're about 2 months of age. Um, the babies who are exposed to opioids or other drugs, they cannot do that. Their brain is not organized, so they have disturbed sleep pattern. So that causes a lot of stress for the caregivers, whether they are parents or extended caregivers, because the baby is getting up at night or sleeping excessively, hard to wake up. And if the parents are not tuned into the baby's feeding need, babies can go 12, 18 hours without food and run a risk of losing weight, getting dehydrated. And also look at the other things that can have an impact on the sleep regulation. Um, other things like the developmental disorders or prematurities can do that. So what can you do while the baby is delayed in achieving this sleep cycle and is 3-4 months of age and still waking up every 2 hours at night? And what we can do is just have the caregivers, parents or other caregivers, take rest during the daytime while the baby is asleep. So we do that while the baby catches up on making them go to sleep or giving them medication so that they can go to sleep. Some people used to do that. And it's very easy because some of these babies are given morphine sulfate for the neonatal abstinence syndrome, and morphine sulfate puts babies to sleep, but it also depresses their breathing. If you give them extra dose, then the babies can stop breathing, and that can be an accidental overdose. So parents need to avoid that. So nutrition feeding issues are because of their immature suck and swallow, and because of other issues of losing calories. So these babies may need high calorie feeding. They may need the tube feeding, which we call the gauge feeding. Some of these babies need to have a whole and a feeding through their stomach. And that can be a medical necessity. And these babies who are throwing up, HG reflux or sensory integration issues, and are compulsive sucking and then throwing up, you need to organize and work with those people. Most of the time, in my clinic, I used to ask the speech therapist and the nutritionist to work together. Speech therapist people work on movement of the tongue for the speech, and they also help in the swallowing function. So if you have a teamwork of speech therapists and a nutritionist, then they can both work on how to make the child with a discoordinated suck um, move their tongue in a way so they can swallow, because sometimes these babies just thrust their tongue out and they don't roll it back to swallow. So those are the things. What about the breastfeeding and substance exposure? Now, moms who are on methadone treatment are going to excrete methadone in the breastfeeding. Most of the drugs of abuse are. Um, and a lot of time people have this, well, baby is going to get this methadone. And so what are we doing? Are we increasing the problem? Well, in a way, the methadone in the breast milk can reduce the symptoms of the baby because they are not going to go through the acute withdrawal. But and you need to weigh that with advantages of the breastfeeding, all the attachment that goes on. Maybe this is the only thing that will help the mother go through the successive treatment program, so we buy in. But we need to also know that if you are introducing other drugs for the neonatal abstinence syndrome, you need to take into consideration that some of the methadone from the breastfeeding is going into baby. So a physician need to adjust the dose of the other medications. We may not need that much to the baby. We also know that these babies, because they are getting a supply over a period of time of methadone, their withdrawal symptoms are going to be extended over a period of time. And they're going to have withdrawal when mom will wean them of the breastfeeding. And so you may be dealing with a 12-month-old child who's still having the neonatal abstinence syndrome because mom is weaning from the breastfeeding, and you need to know that and how we are going to do that. Okay, so minimizing stress is important because babies have to learn lots of things. On the brain connections are increasing at such a rapid pace. In the first 1,000 days of baby's life, the babies are developing new brain connections, 7,000 new connections per minute. And that is incredible, incredible. It's scary when you think about it, how much they are grasping and they are taking in, how much they need to learn. And if the babies are crying, fussing, vomiting, stressing out, they're not going to learn. So we need to avoid extra stress in those babies as a part of treatment. We need to establish the daily routine, avoid excessive stimulation. And I used to teach parents consolability or calming technique for the baby, 6 different steps that you can do within 1 minute to calm the baby down. Just don't stick the pacifier in the mouth at the first sign of the cry. And don't be in a hurry in handling the baby. Approach the baby, ask baby's permission. And a lot of time I saw the parents who were having issue with the substance abuse did not take time to understand the baby's nonverbal cues, and they would just flip the baby up and over, just undressed in one, expose them from the nice warm clothing to the cold, and the babies will start screaming. And babies with the going through the withdrawal, once they start screaming, it is hard for them to come down to the calm state, and the parents get upset, and then they are shaking. And so all of those things can be avoided. Infant massage is a amazing calming technique for the babies, but we need to teach the parents under instruction. And some of your visiting nurses or the social workers or early intervention people can do that, so that we are not being too aggressive in doing the massage for the babies. But that is a very important tool, and the babies do feel very good about that. These are the 6 steps that I use today. I'm going to quickly go over that. Bringing the face of whoever is the caregiver of the baby close to the baby and talking calmly in a very soft voice with the face and voice alone. First with the face alone, bringing the face and letting baby see that there is somebody there to help. Then talking soothly, then holding the baby, bringing the baby's arm in the middle in a W position, and pressing with one hand gently to say that, yes, you are not like an astronaut without gravity floating, because they shake like that, and you're calm. And then holding the babies, we call it horizontally like that, gently, and then putting it on the shoulders, swaddling the baby. And the last is offering the pacifier while doing the rock. So if the baby still is not fully calm, then go back to step 1 and do that. And most of the parents feel very empowered. This is, again, we talked about empowering the parents. When I used to tell the parent they can do I can do all that. Yes, you can do all that, because a lot of time if the baby is crying and out of control and you stick the pacifier and they won't take it, then you don't have any other option. It frustrates the parents and increases the parents' stress. So I think that's a wonderful tool to do. So as far as the medication for the babies are concerned, the goal of the treatment is that babies should be able to have a calm sleep pattern, should be able to eat, gain weight, socially interact well, to decrease stress for both parents and the child, and some of the serious complications of the neonatal withdrawal, such as seizures, which are detrimental to the infant health, don't happen. And 83% of the time we use one of the opioid, morphine or methadone for the babies, and or phenobarbital, and we do according to very measured dose, and that's why the close follow-up is needed. But in addition to these medical management for the baby and providing some education of how to care for those symptoms, child safety, risk assessment, other underlying issues that are confronting the family need to be addressed, because these families don't have just one set of problems. They come with a basket full of problems, and some of the issues you will be dealing with. So comorbidities such as mental health, learning disability in the parents, domestic violence, criminal background, history of childhood trauma. And I am not going to go into the detail because I know you guys are going to have a lecture on that. What are the family's basic needs? How are they being met, or do they have some issues there? And providing that can minimize the stress on the family too. How much extended family support and community network the family has? What are the services that families receiving? Are they overwhelmed? That needs to be addressed too. Is it too much for them that people are coming in and going out of their homes every half an hour, and that it can cause stress too? So just grouping them and over a period of time, monitoring them is important so that the families don't get overwhelmed. And then again, as I said, how does the family people prioritize their concern? What is their main concern? Because we can give them all kind of resources that we have in the community, but if we have not addressed their need and their concern, then we are going to be less effective than we should be. And I think that should be so. Communicating with them and treating them as people is very important, because a lot of time clients came back to my clinic even though they were court ordered for the first visit, but after successful recovery, one time a mother came and I was called to the nursery, you have a newborn baby, and I said, yes. Yeah, you are a pediatrician. I went and I said, well, is it a drug affected? No, it's a normal baby. So I said, well, I usually don't take care of children without special needs. So I went, this mom insists. So I went and talked to the mom, and this was the woman whose older child I had taken care of because she was using drugs at that time. But now she was in recovery, she was doing good, she had a job. And I said, well, you don't have to come back to me because that was court order and I did. So you can have any pediatrician done. She said, no, but I want you. And I got curious and I said, well, every time you're going to come to my office and the clinic door is written Child Protection Center, and some people consider that negatively, it won't bother you. I mean, you don't have issues that dealing with you, and there's no DHS. She said, no, I want to come to see you. I want you to take care of my baby. And I said, why? And I was shocked by her. She said, well, you're the first person who treated me as a person. You're the first doctor who treated me as a person. This woman was in her 30s. It was kind of sad that she did not feel like anybody else in her 30 years of life had treated her as a human being, as a person. And that speaks to some of the issues that these women have, not just substance, why they went into. I was a little bit disappointed in the central CDC's latest recommendation that came out this week. They're asking emergency room people to have the interventions for the substance abuse treatment programs right in the emergency room, because they're having people so much with the opioid overdose coming in. They're even having the emergency medical services people have Narcan available to counteract if the person is overdose. They're asking family members to have that available so that they can administer it at home and then send them. But not once did they talk about, okay, we are doing all these treatment, but did somebody ask these people what started this whole thing? Okay, we are not. And this is Center for Disease Control. They are not still going to that step. To me, that is very important. If we have to, and all the substance abuse specialists, other people working with these families are saying, this is what we need to do. We need to know how did this opioid epidemic get started? How does the people take it? And I hate to say that, but the physicians have to take the blame for that, and so do the drug companies who flooded the market with the pain medications and gave everybody. Okay. And so I think those are the things that we need to do if we have to. But as far as you guys are concerned, by the time you receive the families in your system, they need help on multiple issues, on family issues, on daily needs issues, on childhood trauma issues, mental health issues, and substance abuse issues. So, and I hope some of that is helpful, and I think I will be open for some questions now. We have 4 minutes. So,
yeah. Dr. Shah,
yes.
I'm going to try and see if I can make my question concise. I was really encouraged to see the recommendation about women who are on methadone treatment to still be allowed to breastfeed.
Yes.
One question, I think even in Polk County, we're still learning, and we're getting, and I think judges have different opinions about methadone treatment in general, but it used to be, you're in juvenile court, I won't return your baby until you're off methadone. And I think we're learning that we're getting more and more information that it needs to be a long-term treatment plan, right?
Right.
And so I guess I'm curious what your thoughts are with that information and kind of the long-term plan of, if we have healthy families in recovery that are together, that's ideal.
Right.
But how do we counter then? And I guess the question I have is, what would be recommendations for a mother who is finds out she's pregnant, and either, does she go on methadone, or if she's already on methadone and pregnant, how do we, because ideally we wouldn't get that in the child system at all, but I guess thinking from the big picture, what does that look like?
One of the things, I think people who need methadone. And if you want to cut them cold, which sometimes people did that, especially during pregnancy, they can lose the pregnancy. The child can be dead. And so that's why, and because of the metabolism changes in pregnancy, sometimes methadone dose has to be increased. So one of the things that people forget is, now the baby is born, so somebody should counsel the mom, okay, get together with your substance abuse counselor and adjust the dose of methadone. You may not need that much. So you will still need methadone, but you can bring it down, and that will be beneficial to both mom and the baby. And if the mom is not having withdrawals, and if she's not going back on to opioid or prescription opioid use, methadone is a good alternative choice. And some people need it for up to 4 years. That's a long term. It's not something that you can just quit in a couple of months. So she will need it. And as long as she is working towards her recovery, and she is not being non-compliant towards going and being regularly assessed, her parenting skills can be better when she is taking care of herself. Yes.
Dr. Shah, you mentioned massage as a technique for helping to soothe the baby. Have you seen any benefit for chiropractic care? I had one family that swore by it and said that the baby was much more soothed when they had regular chiropractic appointments.
Well, I would say that many chiropractors, they don't get any training in the child development. and they may not be focused on the very small babies. So, I mean, a lot of time chiropractors try to straighten the kinks in your spine, and the babies have normal curvatures in the spine, and somebody trying to straighten the baby's spine will scare me very much. So, but doing the infant massage, if that is all they're doing, gently and not trying to manipulate too much, depending upon their comfort level with that chiropractic. Yeah, on a limited basis. But I think you have alternative area education agency people and visiting nurses that can come at home and do it.
We
So
have a-
I would go that route.
We have a question online.
Yes.
The person said, I've often heard that doctors say happy baby, happy mother, happy baby, in referring to clients with mental health treatment. Obviously, certain medicines are out of the question to take during pregnancy, but are SSRIs and medical marijuana even a problem? Question mark.
Well, I've already addressed the issue of SSRIs because they can potentiate the neonatal abstinence syndrome. So if absolutely the mother needs that, then again, you need to look at putting her on the minimum dose and then knowing that the baby is going to have a worse of the neonatal withdrawal and will need the medication on that. Now, medical marijuana, I don't know. I haven't had my personal opinion made yet on that. And I don't have any official statement to that, so I can't speak to that. Yes.
How do you deal with the situation where the mother has legitimate medical needs for pain management, and how do you balance that against the needs of the unborn child?
Yes. The opioids are very effective pain medication, but they are not the only pain medication. So if a woman is pregnant and, has gone through a car wreck and or has had to have a surgery that is painful, very short time of opioid containing, less than 4 days, I would recommend. And then switching her to the regular pain medications. I had gone through a foot surgery, a broken wrist since in the last couple of years, and I got opioid prescriptions. And in spite of me telling the doctor, no, I don't want it. I don't want to take it. They gave me, and I never got it filled. Okay, you'll need it for a few days. I think I had, with the major foot surgery, bones cutting off and pins being inserted, I used only one pill on the day of surgery. And I told my doctor, I said, I know broken bones hurt and they're going to be painful. And you have my foot in the plaster, I'll sit still. I'm a kind of person who doesn't want to sit still. And so it's better that I feel a little bit pain and put myself at rest. And I just stayed with Tylenol and Advil the rest of the time. So I think it's the wrong perception. I think we have, and probably we are at fault, medical profession, that you should never ever feel pain in your life. I mean, that's unrealistic to me. You feel a pain, you're alive. That's the bottom line. So little things, you don't need to absolutely eliminate it. Severity of the pain can be brought down by non-opioid pain medications. And you need to tell them, okay, it will you will not pain that much, you will have a little bit pain, but it will not be as bad, so take alternatives. Yeah. Actually, what you are doing with opioid is you're not eliminating pain, you're just anesthetizing your brain pain center so that you're not aware of it. It's still there. So, I mean, it's not a treatment